All right, y'all. Thank you again. Again, what a great honor to be here. And this is again, I'll say it again, one of my favorite conferences, multidisciplinary. You see lots of great folks here. But the size is always nice because it's just a little bit more intimate. Lots of learning going on. So with that being said, I get to jump into single session thrombectomy versus catheter-directed thrombectomy for acute limb ischemia, and then how do I choose? So no relevant disclosures to talk about first, but we'll go into etiology. So again, and a lot of this, my colleague Dr. Dua covered much of this, so I'll kind of get through it quickly. But looking at causes of acute limb ischemia, you guys are very well aware of them, arterial thrombosis versus arterial embolism, and their respective causes. How does it normally present? You guys have seen this too classically, again, with the pain, pallor, pulsiosus, paresthesias, paralysis, and poikilothermia. So these are all, again, important parts of the presentation. This foot is probably already dead. There's nothing to, there probably isn't much to do here, and it's irreversible. But again, you want to try and catch these patients before they get to this point, obviously. So the classification, again, the real delineating portion here is that that class 2B that requires that immediate revascularization. And again, we were talking about litigation. This is a very important piece as far as the timing documentation, when you're able to get to that patient and when revascularization actually commences. So I just wanted to make that important point as well. So how do we understand what's really there? Again, you have the usual suspects. I put a star by MRI because it's super slow. I doubt that there's anyone in the room that's doing MRI for acute limb ischemia, though it's listed routinely, again, as a pretty good imaging modality. I would not suggest using this modality in, again, the acute phase, again, just because of the time difference that it takes. So how do you treat it? Again, there are multiple ways: immediate anticoagulation, operative thrombectomy. You have the endovascular manners of treating, and then you have kind of a hybrid model of being able to get the appropriate treatment and get flow going again. I'd be remiss, of course, as a vascular surgeon, you've got to talk about Dr. Fogarty and his amazing work and how that's truly transformed what we're doing when it comes to limbs that are threatened. Some of the advancements you have, wires that now, I'm sorry, the Fogarty can actually go over a wire and be able to pull the clot out. So this can again be done even in a percutaneous manner, versus the open manner as well. So those are just some important. That's a very, very important piece. And I'll share with you in just a moment why that was important, because as you guys can imagine, what was the mortality rate or what was the limb loss rate for patients that are presented with acute limb ischemia in, let's say, the early 1900s? It was in all likelihood extremely high. And again, the treatment because of the resultant outcomes in patients that had a dead leg, if you didn't treat that appropriately with amputation, then the mortality rate obviously went through the roof. So this is one of the landmark, one of the landmark talks and articles discussing the use of embolic extraction using this novel Fogarty catheter. And can you imagine the excitement and the advancement that made in the treatment of lower extremity disease? So I'm going to switch gears and go over to the catheter-directed thrombolysis and what that means. So there are several steps to it that are important. And again, Dr. Dua touched on these earlier. But I'm going to start with access. Again, this is an important piece. How many people in the room are still not doing ultrasound-guided access? Guys, I hope that you really, really take this into account, because it's not an emergency. This isn't a STEMI or something like that where you need to necessarily go radial. Take your time, do the ultrasound guidance, do it in one stick the anterior wall, get into the vessel, and then advance your wires and catheters. Why is that important? Because if you have 3 or 4 sticks, if you don't do a good job, if you stick the back wall, when you start TPA, they're going to bleed every single time, okay? So I really want to emphasize that to the fellows. Become experts in the use of ultrasound. It definitely helps with the eye-hand coordination, helps with getting the feel, and all those different pieces of the puzzle when it comes to doing effective intervention. Next, you have to be able to cross and treat the lesion. Again, you don't want to just put the catheter up top. If it was that easy, you could put the sheath up, let the TPA run through, and then everyone would be doing what we do. But obviously, it's definitely not that easy. You need to embed that catheter into the clot and allow it to run. The standard for doing this, it varies. Some people use 0.5 milligrams per hour. In my training, we use 1 milligram an hour at 30 cc's an hour based on the concentration, and we let that run overnight. Then you have to do your recheck, and again, look at avoiding bleeding, and again, monitoring fibrinogen and that clean initial stick that we're going to spell the correct way is important. So what are the good things about TPA? One, it's using TPA in catheter-directed thrombolysis is it's percutaneous, it avoids surgery, lessens reperfusion injury because it's a gradual restoration of flow to the limb versus when we do it open, you pull the clot and then there's the rush of flow down to the foot. It also improves clot clearance, the acute clot clearance, and then it's applicable to both acute and chronic peripheral arterial disease. We've all done cases where the wire, you have initial CTO, and then the wire just sails right on through. You discover on intravascular ultrasound, which I'm hoping you're using on every case, that there's a soft thrombus in that vessel. Those are the cases where you don't want to go and try and do an atherectomy or do other types of vessel modification if it's truly soft clot. What's going to happen? You're just going to send that stuff everywhere, and then you turn it into a real case. And then finally, the thing that we kind of overlook a lot is that culprit lesion. What actually caused this to happen? You know, besides COVID and other reasons that we know that have a hypercoagulable state, oftentimes in patients there is a culprit lesion that where the actual clot starts and works its way up. And TPA helps to elucidate where that is. And again, you can see, I mean, from right to left, that's a clean vessel. But what do we see down there? There's a culprit lesion that, again, probably didn't cause this entire thing to go down. However, that's something that likely needs to be addressed. That's probably a high-grade lesion that, again, potentially needs to be addressed. So what is the bad? I find it striking that the European Society of Vascular Surgery no longer recommends the catheter-directed thrombolysis for Class 1 ALI because of the risk of bleeding complications. But they still talk about Rutherford Class 2 being a possibility, Rutherford Class 2A, acute limb ischemia. That's an important piece. And I talk about the ugly, and then we get to the oogly. So that's a step beyond being ugly. I don't know if you guys have ever heard that term before. So major bleeding during acute thrombolytic therapy for acute limb ischemia, the value of laboratory testing. We talked about this earlier, but fibrinogen is not necessarily the most accurate measure of whether or not that patient is going to bleed, and it can really vary. One thing that I want to emphasize to especially the fellows is that there are so many components to doing successful thrombolysis, and if any of those components are missing, you're putting yourself at risk. So educating your nurses on what to check and how important it is to check and the challenges that our nurses have in doing so, you need to make sure that you keep them on board, again, so they're doing that routine testing. Not getting a fibrinogen level and a patient having a major head bleed is an absolute nightmare, okay? And it's a nightmare that you want to avoid. So again, it's still ugly. Like when you look at major and minor bleeding rates, you take that 1% of patients that has a major bleeding episode, you know, that's a devastating complication. And again, something that we obviously want to try and avoid. So here's some other adjuncts. We talked about angiojet and we talked about other lytic therapy that can be used as adjuncts with TPA. Now I want to switch gears and go into single session mechanical thrombectomy and whether or not they work. And I would say that they do. And the technology continues to evolve, and I'm really excited about what we're able to do in the lower extremity with a lot of this new technology. And again, it will continue to evolve and continue to get better. Again, just looking at angiojet, you're looking at JET-I, which is a new device out, all effective, and then looking at STRIDE, where we're using, again, mechanical thrombectomy in a way to clear clot, and it being extremely effective in that manner. So, all that to say, how do I choose? I will say that in my practice, as I've gotten older and the more that I talk with, again, my colleagues that have started to age, in the beginning, I was a big proponent of using TPA, catheter-directed thrombolysis, and now I've really moved away from it quite a bit. It only takes so many, takes so many times where you have bleeding in the groin, major bleeding in the groin, you have major bleeding, again, the brain, or even the spinal cord, something like that. Again, it's absolutely devastating and something that you don't forget. So here we got our classic patient with acute limb ischemia, and we're going to just kind of quickly take you through this case. So we've got evidence of thrombus, and again, you've got slow flow going through. The TP trunk looks diseased, and there's also anterior tibial disease. I'm a little bit different, and I guess as a surgeon too, I can. It's not that I can push the envelope because most of the things that I get into, I have a plan on being able to fix it. So in these cases, what I found is the bigger the better when it comes to French size. When I treat the SFA for acute embolic disease, I almost automatically put it in a 12 French sheath. I don't put anything smaller than that. The 12 French aspiration devices work extremely well. You have to watch out for blood loss. Here we've got a culprit lesion, we got an anterior tibial lesion here. We've kind of uncovered, we've got flow into the perineal and there's also some clot there. I got retrograde access in the dorsalis pedis, carried that up and gained single wire control. We then continue to we continued our treatment down. I'm just going to kind of skip ahead. We've got our wire all the way down into the dorsalis pedis and into the pedal arch. At this point, there was still some clot and a lesion a little bit higher up that I could not get out with my mechanical thrombectomy device. You see, I did place a woven stent in the SFA, but we do clearly have flow all the way down into the dorsalis pedis and into the foot. This patient had a palpable pulse at the end of the case. Always use IVUS, of course, and we got a good outcome. So, in summary, again, acute limb ischemia requires rapid assessment, and appreciation of timeline is critical factor and influence in our outcomes. Multiple modalities are available, including surgical, endovascular, and combined therapies for treatment. The risk of bleeding with catheter-directed thrombolysis is real and must be taken into account when choosing definitive therapy. And again, I'm excited about the new technologies that continues to transform this space. Thank you so much.